Good afternoon, dear students. Today we have a lectures in Propaedeutics of Internal Medicine, and it will be the last lecture for groups for this year. You are finishing your third year of studying. You are finishing Propaedeutics of Internal Medicine, and now we have a last lecture from this discipline. The topic of our today's lecture is syndromes in diseases of blood system. It is as usual online lecture, but you still have practical classes, and from the next Monday they will be offline, and we will waiting for you from the Monday in our department. That's why please keep your attendance. If you have rework, do reworks with your practical class teachers, because in 1 month you will have a final control in Propaedeutics of Internal Medicine. That's why now you have a chance, you have possibility to revoke every problem that you have. Okay, and what about today's lecture? It is another system, and all this system we will discuss in one lecture. Of course, this field of internal medicine, we name it hematology. It is very big and quite difficult for understanding and for learning. That's why it is impossible to include all important information in one lecture, but I try to give the main information, the main moments, and we will discuss just the main terms and main syndromes in hematology. And one of the most often of them we name anemia. What is anemia? It is a decrease in amount of red blood cells or hemoglobin of the blood, or lowered ability of the blood to carry oxygen. Causes of anemia. It is impaired red blood cell production. It is increased red blood cell destruction or blood loss or fluid overloading. And on this scheme, on the slide, you see our main causes of anemia. Yes, it is excessive bleeding, yes, due to blood loss. It is menstrual bleeding. According to impaired production, it can be iron deficiency anemia. It is the cancer causing anemia. It can be genetic factor that causing anemia, or for example impaired metabolism or of spleen and anemia. It will be anemia due to increased red blood cell destruction. Causes of impaired production. First of all, it is disturbance of proliferation and differentiation of stem cells. It can be in pure red cell aplasia, in aplastic anemia, in anemia for renal failure, and anemia of endocrine disorders. Disturbance of proliferation and maturation of erythroblasts, like for example in pernicious anemia, anemia of folic acid deficiency, megaloblastic anemia, anemia of prematurity, and iron deficiency anemia. Moreover, it can be thalassemias and congenital dyserythropoietic anemias. Other mechanisms of impaired red blood cells production, like myelophthisic anemia, myelodysplastic anemia, and anemia of chronic inflammation can be, but in more rare case. Causes of increased red blood cell destruction. Here the opposite situation, when it is enough erythrocytes were produced, but it is increased destruction of them. It can be intrinsic and extrinsic, intrinsic or intracorpuscular. It is abnormalities cause premature destruction, except paroxysmal nocturnal hemoglobinuria, are hereditary genetic disorders. And it can be extrinsic or extracorpuscular abnormalities, like antibody-mediated mechanical trauma of red blood cells. And here you see comparisons into pictures of patient with a normal amount of red blood cells and anemic amount of red blood cells, and microscopically it usually looks like this. Okay, next group of causes, it is blood loss. Yes, what it can be? It can be anemia of prematurity. It can be trauma or surgery causing acute blood loss. It can be GI tract lesions like acute bleeding from peptic ulcer, from chronic blood loss or angiodysplasia. It can be gynecological disturbances, and it is a very often cause that lead to usually to chronic blood loss. Moreover, it can be menstruation among young women and older women with fibroids. Yes, it is increased volume of menstruations. And it can be infection by intestinal nematodes feeding off blood. Okay, what is hydramia? Hydramia, it is fluid overload or hypervolemia with hemodilution. Normal total amount of hemoglobin and red blood cells in the body can't make normal function because the solution, the concentration them into the blood decreased due to overloading of fluid. It can be in excessive sodium or fluid intake, in sodium or water retention and fluid shift into the intravascular space. And it can be anemia of pregnancy with induced by blood volume expansion experienced in pregnancy. Diagnostic steps in anemia diagnosing. Yes, we check for clinical manifestations, for hematological syndromes like blood test abnormalities, blood biochemistry abnormalities, and bone marrow abnormalities. Okay, what clinical signs and symptoms? First of all, they are not specific, but the most often symptoms, it is weakness, fatigue, general malaise, and poor concentration. It's such a non-specific syndromes that usually patient cannot pay attention for or refer them to some other chronic conditions, and due to such unspecific symptoms, often in patients, especially in aged patients, anemia stay undiagnosed. In most severe cases, it can be dyspnea or shortness of breath on exertion. For anemia, it is characteristic increasing cardiac output, palpitations, angina if pre-exciting heart disease is present, heart failure. It can be intermittent claudication, and it is very typical pale skin, lining mucosa, conjunctiva, and nail beds. That's why, please remember, during objective examination of patient, always pay attention to the skin and its color and color of mucus of patient. The most specific and quite simple method for check for anemia, it is check conjunctiva for some paler. If it's pale, you can suspect anemia. Additional signs of severe anemia. It can be hyperdynamic circulations with tachycardia, bounding pulse, flow murmurs, cardiac ventricular hypertrophy. It can be signs of heart failure. It can be pica and restless legs syndrome. It's very typical for iron deficiency anemia. Okay. Diagnostics of anemia. Additional diagnostic tests. Here, of course, we pay more attention to laboratory tests. It is laboratory syndrome. And what should we do? First of all, it is CBC, complete blood count, with checking of usual checking number of red blood cells, white blood cells, hematocrit, and some general blood features. Moreover, we should check blood smear, hemoglobin level, hematocrit level, red blood cell size, not just count, size too, reticulocyte count, and reticulocyte production index. That's why okay, we nearly always do CBC for all patients with different pathologies, but if you suspect anemia, please detailize for your laboratory that you need complete blood count with all possible indexes. It is size of erythrocytes, reticulocyte, whole leukocyte formula, and other indexes of CBC. And here on the picture you see methodic how to do CBC, complete blood count. For today it is electronic. And just on electronic analyzers we put their piece of blood and it analyzes all these indexes. But more old information, and still it is more accurate subjective evaluation by the human for CBC, just for CBC. Previously it looked like this, that a drop of blood, like here from the finger, it is capillary blood, it is centrifuge in the hematocrit tube, and after it, according to such simple scale, we can check hematocrit levels, white blood cells, platelet formed by Buffy cut, and red blood cells. Okay, anemia. For diagnosing anemia, we know that it is decreasement of hemoglobin level. We have to know a normal level of hemoglobin. Here you see World Health Organization hemoglobin thresholds using to define anemia. Here you see two thresholds in gram per deciliter and millimoles per liter. Yes, and you see the ranges for children till 5 years, children after 5 years, for teen, woman non-pregnant, pregnant woman, and for male patient older than 15 years. Okay, color index. According to color index, we can classify anemias for normochromic when it is normal color index from 0.85 till 1.05. If we see another signs of anemia, but their color index is normal, it can be in acute post-hemorrhagic anemia or hemolytic anemia. If in anemia color index is less than 0.85, it means we name it hypochronic anemia. It's possible for chronic post-hemorrhages. One more time, in acute period just after hemorrhage, it usually will be normochromic, and in more long period or in chronic hemorrhage, it will be hypochromic. And it's very typical for iron deficiency. And the opposite, if color index is elevated more than 1.05, we name anemia hyperchromic. It's very typical for B12 vitamin deficiency, folate deficiency, or for aplastic anemia. Okay, we have a little bit another classification of anemias due to red blood cells size. According to what size of red blood cells, we divide anemia on normocytic, when it is normal size of the cells, like for example in anemia of chronic disease. When it is when cells are small, we name it microcytic anemia. Small, it is less than 80 fluorescence. What is the most typical? The iron deficiency anemia. And when cells are large, we name it microcytic anemia. It is when the red blood cell size more than 100, and it is specific for B12 vitamin or folate deficient anemia. Okay, and one more moment from anemia that I want to discuss. It is regenerative ability of bone marrow reticulocytes. Yes, if we have some deficiency of red blood cells, some deficiency of hemoglobin, organism, of course, trying a normal organism in a health state, trying to compensate this situation and produce more red blood cells and their more early forms. And according to these more early forms, what the most interesting for us, it is reticulocytes. We can check the level of regeneration and compensation of this anemia ability of organism to compensate anemia. According to it, we can divide all anemias for normal regenerative. It is from 6 to 12 percentiles. It's possible in anemias due to deficiency as iron, as B12, as folate, for all of them. It can be hyperregenerative anemias. It's more typical for hemolytic and acute post-hemorrhagic anemia. And we have patients who are not able enough to regenerate red blood cells. We name it hyporegenerative when reticulocytes less than 6 percentiles. It's typical for aplastic anemia. Okay. What else? Not just complete blood count. What else laboratory parameters we can check to help for yourself for diagnosing anemia? First of all, we check biochemical blood analysis and different parameters for anemia. One of the most specific of them, it is level of ferritin. It will be decreased in iron deficiency. Moreover, we usually check serum iron. It will be decreased in iron deficiency too. Transferrin saturation, the same, decreased in iron deficiency. Moreover, we should check red blood cells folate level. Here is understandable that it will be decreased in folate deficiency. Level of serum vitamin B12, serum methylmalonic acid and homocysteine. It is important for B12 deficiency. Renal and liver function test and erythropoietin level for checking different types of anemias. Okay, next syndrome for today. Okay, our next syndrome for today we name polycythemia. What is polycythemia? It is a myeloproliferative condition that results in an increased level of circulating red blood cells in the bloodstream, with increase in hematocrit, hemoglobin, or red blood cell count above the normal limits. Synonyms of polycythemia, and you can find them in a different literature. It is erythemia, or Osler-Vaquez disease, or polycythemia rubra vera in Latin, or primary polycythemia, or splenomegaly polycythemia, Vaqueous Osler disease, and polyglobulia. It is a little bit other. It is a little bit different conditions, diseases, but all of them are connected with one syndrome of polycythemia. Risk factors for polycythemia. It is hypoxia from long-standing chronic lung disease and smoking, for example, asthma or COPD. It is chronic carbon monoxide exposure, for example, for some professional conditions or occupational disease. People living in high altitudes due to low environmental oxygen levels, and people with genetic mutations and familial types of polycythemia and certain hemoglobin abnormalities. Causes of polycythemia. They can be primary and secondary. Primary causes, it is slow growing type of blood cancer. Yes, it is a very serious disorder. Or another name of these disorders, polycythemia vera. It is real polycythemia. And another disorder that can be, it is primary, familial, and congenital polycythemia. Just in these two cases, it will be primary. When it caused by something else, by another chronic or acute disorders, it names secondary polycythemia. What it can be? First of all, it can be physiologically appropriate, for example, adaptation to living at high altitudes or iatrogenic. It can be due to chronic hypoxia, what I told, it is COPD, hypoventilation syndrome, chronic heart disease, sleep apnea, pulmonary hypertension. It can be erythropoietin secreting tumors like hepatocellular carcinoma, renal cell carcinoma, adrenocarcinomas, and uterine tumors. And it can be relative polycythemia, when the underlying cause is reduced blood plasma. Signs and symptoms of, let's take the most severe, most dangerous disease, polycythemia vera, because it has a most bright, a most specific clinical picture. Here will be trouble breathing when lying down, very typical dizziness, excess bleeding, full feeling in the left upper abdomen due to enlarged spleen. It is headache, it is itchiness, especially after warm bath, red skin coloring, especially of the face, shortness of breath, and phlebitis. Other symptoms that may occur with polycythemia vera, it is bluish skin color, fatigue, red skin spots, and vision problems. Like you see on this photo, it is patient with polycythemia vera. You see how a specific skin changes. Diagnosis. For confirm polycythemia vera, we need bone marrow biopsy. To suspect polycythemia, it is enough complete blood count with differential diagnosis, comprehensive metabolic panel, erythropoietin level. Moreover, we have confirmed genetic factors that predispose to this disease. It is genetic test for this specific mutation that you see here on the slide. Moreover, we usually check oxygen saturation of the blood, red blood cell mass, and vitamin B12 level. According to World Health Organization, we have such a criteria for diagnosing polycythemia. We have major and minor criteria. Major criteria, it is hemoglobin more than 18.5 grams per deciliter in men and more than 16.5 grams per deciliter in women, or other evidence of increased red blood cell volume. And second major criteria, it is a presence of this specific genetic mutation or other functionally similar mutation. Minor criteria. It is bone marrow biopsy showing hypercellularity for age with tri-lineage growth like panmyelosis with prominent erythroid, granulocytic, and megakaryocytic proliferation, all three types of blood cells. Serum erythropoietin level below the reference range for normal, and endogenous euthyroid colony formation in vitro. Diagnosis. The polycythemia vera study group criteria diagnosis is established at three categories. Category A criteria are present, or if category A1 plus category A2 plus any two criteria from category B are present. It is general diagnosing. Okay, one more time. Criteria. Category A. Total red blood cells mass more than 36 milliliters per kilogram in males or more than 32 milliliters per kilogram in females. Second category A criteria, it is arterial oxygen saturation more than 92 and splenomegaly. Category B criteria. It is thrombocytosis with platelet count more than 400. Leukocytosis with white blood cell count more than 12,000. Increased leukocyte alkaline phosphatase more than 100 units per liter, and serum vitamin B12 concentration more than 900 picograms per milliliter, or beating capacity more than 2,200 picograms per milliliter. Okay, next syndrome for today we name leukopenia. Leukopenia or leukocytopenia is a decreasement of white blood cells or leukocyte present in the blood that places individuals at greater infection risks. Causes of leukopenia. Most often it is viral infections like colds, flu, HIV, and AIDS. Microbial infections. It is sepsis, psittacosis, rickettsial infection, tuberculosis, malaria, and dengue, etc. The cause of leukopenia can be autoimmune connective tissue diseases like rheumatoid arthritis, systemic lupus erythematosus, etc. Cancer or other diseases that damage bone marrow like leukemia, myelofibrosis, and Hodgkin's lymphoma. Congenital disorders like Costmann syndrome or myelocataxis. Vitamin deficiency like folate deficiency. Deficiency of minerals, for example, zinc, copper, etc. And medication and radiation therapy like diuretics, antibiotics, antipsychotics, and antidepressants can be causes of leukopenia too. Signs and symptoms of leukopenia. It is very often associated with anemia and thrombocytopenia. It can go with some infection disorders like pneumonia, stomatitis, oral ulcer, and various infections, liver abscesses, metrorrhagias, menorrhagias, neurasthenia, fatigue and hot flashes, strong desire to consume hot drinks. According to diagnostics, leukopenia can be identified with complete blood count. Yes, it is a simple test and it is enough to diagnose leukopenia. Another syndrome, we name it leukocytosis. What is that? White blood cells leukocyte count above the normal range in the blood. Five principal types of leukocytosis and its causes. According to what type of leukocyte, hope you remember from physiology and pathophysiology that it can be a lot of types of leukocytes. It can be different types of leukocytosis too. If it increased due to neutrophils, we need neutrophilic leukocytosis or neutrophilia. It's the most typical for bacterial infections and tissue necrosis. If it is increased due to eosinophils, we name it eosinophilic leukocytosis or eosinophilia. It's possible in bacterial infections, in in allergic disorders, in parasitic infections, malignancy, systemic autoimmune diseases, or acute stress. Basophilic leukocytosis or basophilia. It's typical for myeloproliferative disease. Monocytosis, the most typical for chronic infections like tuberculosis, systemic autoimmune disease. And lymphocytosis can be in chronic infections like tuberculosis, brucellosis, viral infection, what the most often, and pertussis and malignancy. Signs and symptoms of leukocytosis. Okay, the most often it is fever. That's why, because you remember that most of the clinical signs are due to infections, and it is the most often cause of leukocytosis. It can be not just fever. It can be bleeding or bruising. It can be feeling weak, tired, or sick, feeling dizzy, faint, or sweaty, pain or tingling in arms, legs, or abdomen, trouble breathing, thinking, or seeing, and losing weight without trying or a poor appetite. Yes, and to arrange much more different symptoms due to different infections. And for diagnostics of leukocytosis, we need a complete blood count too. You remember such a simple test and such a lot of information it gives to us. Okay, excessive numbers of white blood cells are most often due to response of normal bone marrow to infection or inflammation. In some instances, leukocytosis is a sign of more serious primary bone marrow disease. We name them leukemia or myeloproliferative disorders. Let's discuss them. What is leukemia? Let's give definition to it. It is abnormal proliferation of the blood-forming tissue that usually begins in the bone marrow and results in high numbers of abnormal white blood cells. Causes of leukemia. It can be mutations in DNA as a result of exposure to radiation or cancerogenic substance, and genetic predisposition to this leukemia. Classification of leukemias. According to cell type, it can be lymphocytic or lymphoblastic leukemia and myelogenous or myeloid leukemia. According to its course, it can be acute or chronic, and we have in both types, we have both cell type. It can be acute lymphoblastic leukemia or ALL. It can be acute myeloblastic leukemia like AML, chronic lymphocytic leukemia SLAL, and chronic myelogenous leukemia SML. CML. Okay, signs and symptoms of leukemia. It is a range of different symptoms, but the most often of them it is fever or chills, persistent fatigue, weakness, frequent or severe infections, losing weight without trying, swollen lymph nodes, enlarged liver or spleen, easy bleeding or bruising, recurrent nosebleeds, teeny red spots in skin like petechia, excessive sweating especially at night, and bone pain or tenderness. Acute leukemia. Acute leukemia is characterized by a rapid increase in the number of immature blood cells. We name it blasts. Crowding due to such cells make the bone marrow unable to produce healthy blood cells. Immediate treatment is required in acute leukemia due to the rapid progression and accumulation of malignant cells, which then spill over into the bloodstream and spread to other organs of the body with a very rapid progressing of malignant process. Chronic leukemia is characterized by the excessive buildup of relatively mature but still abnormal white blood cells, typically taking months or years to progress. The cells are produced at much higher rate than normal, resulting in many abnormal white blood cells. Mostly occurs in older people but can theoretically occur in any age group. Diagnosis. For diagnostics of leukemia, it have to be repeated complete blood counts and blood films, yes, to check in to identify these young forms that we name blasts, checking their number and their forms. It is testing for Philadelphia chromosome in chronic myeloid leukosis, for bone marrow examination, a lymph node biopsy, what is the most important for lymphoma, and detailizing for metastasis for lymph nodes. For some formations, we use visualization like X-ray, MRI, or ultrasound. Next syndrome for today, it is hemorrhagic syndrome. What is hemorrhagic syndrome? The extravasation of red blood cells from the vasculature into the skin or subcutaneous tissue in form of petechia, purpura, and ecchymosis. It is collectively referred as a purpura, with purpuric rashes formation. Moreover, let's add to definition that extravasation occur internally, where red blood cells leaks from the blood vessels inside the body. Forms of purpura. Yes, I name in definition petechia, purpura, and ecchymosis. What is that? Petechia we name at pinpoint red lesions less than 2 mm in size. What is purpura? Purpura, it is pinpoint red lesions from 2 to 10 millimeters in size. Like on this photo, it is photo of purpura. And ecchymosis, it is pinpoint red lesions more than 10 millimeters in size. You see that here some of points go together, and you see the ecchymotic places. Principal types and causes of hemorrhagic syndrome. First group of problem, it is thrombocytopathy. Any of blood disorders characterized by dysfunctional platelets, thrombocyte, with either normal platelet counts, non-thrombocytopenic purpures, or decreased platelet counts, like thrombocytopenic purpures, which result in prolonged bleeding time, defective clot formation, and tendency to hemorrhage, like in Henoch-Schönlein purpura or Willebrand disease or thrombasthenia or platelet aggregation. Second group of diseases, it is hemophilia. It is a group of hereditary genetic disorder that impair the body's ability to control blood clotting, which is used to stop bleeding when a blood vessel is broken. For hemophilia A, it is clotting factor A deficiency, the most common form of the disorder. For hemophilia B, it is factor 9 deficiency, occurs around about 20,000 to 34,000 male births. And next group of disorders, next syndrome, it is telangiectasia. It is small dilated blood vessels near the surface of skin or mucous membranes, measuring between half and 1 millimeters in diameter. Signs and symptoms of hemorrhagic syndrome. Of course, first sign, it is a purpura. Sometimes it associated with mucosal bleeding. We check it for localization and distribution. Moreover, often hemorrhage accompanied with arthritis and arthralgia. It can be central nervous, gastrointestinal, cardiovascular, arterial system involvements, according to cause of this hemorrhagic syndrome. Typical prolonged heavy menstrual period, we name it menorrhagia. It can be unexplained nosebleeds, very typical for hemophilias. Extended bleeding after minor cuts, blood draws or vaccinations, minor surgery or dental procedures, and bleeding after aspirin. Classification of hemorrhagic syndrome according to World Health Organization. It is grading scale to measure the severity of bleeding. Grade 0, it is no bleeding. Grade 1, it is petechial bleeding. Grade 2, it is mild blood loss or clinically significant. Grade 3, it is gross blood loss. It requires transfusion or severe blood loss. And grade 4, it is debilitating blood loss, retinal or cerebral, associated with fatality. Hemorrhagic syndrome usually refer to grade 1 or petechial bleeding. Diagnostics of hemorrhagic syndrome. We check for platelet count, platelet function, bleeding time, platelet aggregation studies, for Willebrand factor studies, and specialized tests. Moreover, we should do a coagulation screen. It is clotting factor deficiency. We check clotting factor, especially that can be involved the most often factor 8 and factor 9. If the patient is on warfarin, it is anticoagulant drugs, we should check international normalized ratio or INR. And moreover, we can check patients for autoantibody screen for connective tissue disorders. Okay, it was the main moments about syndromes in hematology in blood disorders. It is a very compact, very short information. If you need more information, please read it individually. You can discuss it with your practical class teacher, or our department prepare for you a study book for Propaedeutics, and now during a month it will be ready of book about blood system disorder, especially for Propaedeutics. It is very interesting. It consists of a very important and very interesting, very useful information for you. That's why from the next semester, if you are interested in hematology, in internal medicine in general, please contact the department about this book. And for today, that's all. Now we're finishing our cycle of lectures in Propaedeutics of internal medicine, but I'll see you next semester in internal medicine with endocrinology, and we will start the cycle of lecture. It will be mine about endocrine disorders. It will be much more interesting for you, because from the fourth year, from the next semester, internal medicine will include more clinical, more syndromological information, and it will include clinical features and treatment of all diseases. That's why it will be more difficult, more interesting, and more useful for you and for your future practice. That's why who have problems, who have absent, please decide these problems with your practical class teacher, do all your reworks. See you on the final tests and next semester. For today, that's all. Goodbye.